swelling, and the postoperative yearly OCT, yearly vaulting measurements and assessment of cataracts, everything will be different. So next talk is by Dr. Anup Chirayath, Senior Phaco Surgeon and Managing Director of iVision Eye Hospitals, Thrissur. His talk is on refractive lens exchange, utilizing the multifocal armory. Over to you, Dr. Anup.
Ideally, I think we could have just have had a roundtable discussion because there is only that many people here. So refractive lens exchange, just to complete the armamentarium of correcting refractive errors, is nothing but removing the clear lens to correct these refractive errors. So the benefits is as for any other refractive procedure, but the additional thing maybe as a selling point, you can tell that you won't get cataract in the future. So that is patient for them, it may be something impressive. So exclusion criteria, again, all those which are there applies for any refractive surgery. In addition, those patients with risk factors for retinal detachment, especially if you are planning to do in myopes, those patients should not be taken. And those with ocular inflammatory diseases, because obviously it's an intraocular procedure, you may aggravate those problems. Since it's a precision surgery, because the patient doesn't have any cataract, already has good vision. So if you want to do surgery on this patient, their expectations will definitely be high. So definitely, even if you are not able to correct the refractive error fully, at least you should not introduce any complication because of your some certain wrong preoperative evaluations or measurements. So your biometry should be on the dot. Always better if you have optical biometer. But even a ultrasonic biometer with immersion, if it is done properly, is good enough. But definitely the formulas that you use should be the advanced newer formulas like the Barrett's Universal 2 or the Kane formula. Both are very easily available, so that your calculation of the lens power should be on the dot. And then if you have these higher end anterior segment evaluating machines like the where you can measure the angle alpha and kappa. So especially if you are doing in a presbyopic patient, if you are doing so there, this is important. These angles are important. If they are more than 0.5, those patients one should not be taking up. And these machines will also give you the higher order aberrations which the patients may have. So if they have significant higher order aberrations, those patients also at least you should not take up for a presbyopic IOL correction. So this can be done, RLE can be done in myopia, hyperopia, presbyopia and astigmatism along with all these combinations. In myopia, of course, there is always a risk of retinal detachment, especially going for those with higher ranges of myopia, more than 6 diopters. The incidence of retinal detachment can be in the range from 2 to 8%, depending on various studies they have shown. And in young patients, the risk is more. And of course, if you have intraocular complications like a posterior capsular rupture, or if you have to do a YAG capsulotomy postoperatively, this risk will be multiplied. It can, complications in myopia, especially risk of RD, can be reduced to some extent by doing prophylactic barrage laser if you have any degenerations, or in postoperative also you have to really follow up properly with indirect ophthalmoscopy. But all in all, I always try to avoid, personally, I don't do refractive lens exchange in those with myopes. Only if they have cataract, only I touch them, because there is no point honestly subjecting them to this risk of. And I have had a case where the patient did get an RD after a few months of time. So once you have such a complication, then you generally learn from that. But in hyperopia, it's a different ball game altogether. Here, refractive lens exchange is definitely much safer, and the results also definitely much better than any other corneal refractive procedure. So here you can very safely go in with this. And the additional advantage is that many of these patients have a shallow anterior chamber. They are predisposed to closed angle glaucoma. So if you do a refractive lens exchange, the angle opens up, and you, in addition to the refractive correction, there is an additional advantage that you are preventing angle closure glaucoma. The only problems in hyperopia is that these are intraoperative problems. Because of the shallow anterior chamber, definitely the procedure is more difficult, because there is very less space wherein you have to maneuver. And because of the same thing, the chance of endothelial damage is also more. And the chance of intraoperative hard eye is more in those with hyperopia, probably because of either uveal effusion or aqueous misdirection. So this was a young lady with around 31 years of age. She had +7 diopters of refractive error. So after surgery, before surgery, her uncorrected vision was just finger counting. So after surgery, she got almost 612, which was the maximum correction possible with refraction, and she was really thrilled. I had to use a +39 diopter lens. Here, of course, I don't think presbyopia correcting lenses are available in these sort of powers. But then if you do for both eyes, and if you make either go for emmetropia, or if you make one eye slightly myopic, -0.5, they are more than happy. And then there is no fixed rule that you have to use only premium lenses for refractive lens exchange, provided your patient selection is good. Like this patient had almost 2.75 diopter, +2.75 diopter. So even with the enhanced monofocal, the patient was very happy. But of course, you have to convince them that they have to do both eyes at least in a small gap of time. Not that one eye after now and one after 6 months or so, because then by that time they will never be happy because they have to use high power in one eye. So we always tell them that if at all you go for surgery, you better plan it like this, where you have a time to do both eyes. We always do one eye and then the other eye after 5 days. So we tell them beforehand. And then similarly, even simple, very normal lenses, normal packages also can be done with this. And you just give them a monovision, and in the dominant eye you make them emmetropic, and the non-dominant you give them around 0.5 to 0.75 of a myopic this thing, and they are really happy. And refractive lens exchange in presbyopia, now we have got a huge range of lenses available. All this, and in addition to this, the EDOF lenses also. But here, of course, you have to tell them about, if you are using a diffractive sort of lenses, you have to tell them about these problems, because before this, they are using glasses, but they don't have any of these issues. But now you make them free of glasses, and then you gift them some additional problems which they didn't have beforehand. So they may not be really happy. So here you really have to tell them about this. They can get these issues, and then only you take them up for surgery. So this was a EDOF diffractive lens. So here again, like I said, since it's a precision lens, even a small diopter, this patient had half a diopter of astigmatism along with the spherical power. So here, in such cases, you mark the steep axis if it is in the accessible regions. Because if it is not in the accessible, like superonasal or inferotemporal, you can't do anything about it. That's better not to select such cases. But here, since it was accessible, and you do put your incision on the steep meridian, you can again chop off around 0.25 to 0.3 diopter from the 0.5. So the patient has almost emmetropia. And in the end of it, you have to see that the IOL is well centered. Your Purkinje's reflexes you should see under coaxial illumination, and they should be within the central most ring. So you are sure that your IOL is well centered on the visual axis. Now the non-diffractive EDOFs have come. I personally have found them, in my experience. I've been using them now for some time, and the patients are really happy, because these problems with glare, halos and starburst, those are significantly less. I was always I personally am very afraid of these problems, because you imagine, I am also very finicky about my sight. A little bit, even a 0.25 cylinder changes, I get disturbed. So that I can just empathize with these sort of patients, because I can't imagine having to live with, to see a point light with a full halo around it, as though you're looking through a fog. So I never was a very big fan of all these diffractive lenses, but now once this non-diffractive have come, I've been using them quite a few, and they are happy in the sense they may not get N6 for near, but then they don't have the problems of halos and glare. And so most of them are really quite happy. So this is also probably one of the very effective ways of correcting pre-existing refractive errors. And definitely, if you select the patient well, you can give them good correction and make them happy. Thank you.
Thank you, sir. As sir told, RL is effective, giving excellent results in selected and motivated patients. I have one question. Do you counsel? Do you recommend refractive lens exchange in your regular patients?
For only those who say that they want to get rid of glasses, and then those people who have say +3 for distance or plus more than +2. I suggest to them that you don't have much any cataract, even if they have just cortical. I tell them you have minimal cataract, but the advantage is that you will get excellent. You will be very happy post-operatively. Your vision without glasses will be good, and even reading also you will be able to manage somewhat. Even if you give a enhanced monofocal, you will definitely be good. Is the assurance I give them. So it is up to them. If they choose, yes, we do.
Hyperopic with early cataract patients are the ideal patients. Thank you.
So if the axial length is going beyond with the normal IOL formulas, I have seen you showing the Kane formula. Which other formulas you prefer for a very high myope, very high long axial length?
We generally, I mostly use the cane, and with that we have got good results only. We don't use the Barrett's or anything. And even the Holiday 2 and all, we have not really using them much. So with this, I have to, I've told the optometrist to make every month, I tell them to do a study of all these abnormal powered lenses. And they will give in the end of the month whether there are any surprises. So with cane, somehow I've never had any surprises. I don't know.
Online calculator you do.
Yeah.
And you do monovision for this, or if they don't
Yeah.
use spectacles?
I always try to do a monovision for them. Yeah, if they are using a monofocal lens.
Yeah, Dr. Anup, a very nice presentation. What's your preferred lens for a like hyperope? Will you prefer VT, pure C, or
Nowadays, I am preferring pure C or eye-hands or pure C.
Okay.
Both of these lenses, even for those many surgeons, doctors, and all, they're coming putting these lenses, and they are happy actually. Even active surgeons and all.
Pure C is the like if you want good intermediate vision.
Yeah.
And yeah, for surgeons and all, pure C is the one that you.
Yeah, pure, even IONs, they are good because IONs also they say up to almost 40 or this thing they can get. So one general surgeon, he came post-op after 2-3 months. I asked them how's things. He said, I'm very happy, comfortable. Without glasses, I am operating because they operate at this distance.
Yeah.
So they seem to be happy with that.
Optimum intermediate vision.
Clarion. The Clarion I have not used much actually, so I'm not in a position. That you say that also gives good results.
Yeah, I am comparing a study on Swissfob and Clarion. And the intermediate vision is almost like I have not done the analysis, but almost the same. Good intermediate vision.
Okay, yeah.
Clarion is also.
Clarion also.
Clarion monofocals.
Okay. I have not used much of that.
I just want to make a comment regarding the myopes coming for this refractive lens exchange. So I had a patient, somewhat VIP. He came to me because he was a high myope. I was not at all willing to operate on him. So he went to US, and US 2 places he went, and they suggested this. He wanted, I think, some intermediate vision glass. This one. Then I operated, and then he is actually able to read N6, but he is very unhappy because in myope, I think generally we only some part of the light is going into the near vision. So in a myope, if they remove the glasses, everything is going to near vision. We can never match that. So that is a very important thing. So myope, you had to be extremely careful regarding RLE.
But only the low to medium myopes, no? Those with say -5 and 6 and all.
This guy had -8. But I think he had a habit of lifting up and reading. So that's, I think I told him not to get operated. Then he wanted, like after getting opinion from US, then he got into trouble.
Their natural near vision.
Yeah. That you cannot give.
Before touching, you have to ask them whether, like, how is their regular routine practice. Whether they lift up the glass, then don't touch it. If they read with glasses, then okay.
And one other I wanted to ask, how like you all Indian, the smart fob, and even the Oral Lab has come out with. So, what is your opinion with these sort of lenses? Kiran, you use smart fob, you know? Indian ones. Swiss fob. Swiss
Aurora
fob.
Lab, that one is, I think, Aurora Lab EV or something.
Yeah,
that
yeah.
one.
Now
That
they
is,
have,
that
yeah.
is quite good, I think.
Good.
I used very few.
Few hours.
The problem with eye hands is that it sometimes gives spectacular results in certain group of patients, and sometimes it just behaves like a normal monofocal.
Monofocal, yeah.
So we're not really sure which one. So we don't actually counsel them that this is going to give you a. We kind of use this as simply a premium form of monofocal. Both Clarion and eye hands. Eye hands seems to slightly give better results. Again, these are simply anecdotal experiences. One thing I wanted to ask you, anybody can answer this. What are the IOL formulas you use for post-LASIK eyes, post-PRK eyes? And would they, what about what happens when these clear smile patients undergo cataract surgery later? Would that, is there any impact on the formulas? Anything different?
I use True K Barrett True K and IOL Master
post-LASIK?
700.
So for
We-
smile and anything changed any of that?
Smile, I don't have much experience, but post LASIK, post RK, very predictable results and no hyperopic. They won't go for the hyperopic shift.
Shamas also, we use Shamas.
Shamas, we
That
use
also gives quite on the dot results, yeah.
No, I tend to use Barrett True K. That is one thing. Then I calculate the
yeah.
K also, like that formula is there. No?
Yeah. Mechanically you calculate.
Mechanically
yeah.
we can calculate the K.
Yeah.
Then as a third measure, you can take the pentacam or the topography machine, the central 2 millimeter area. And three values if you take the K, and then you get a proper result, because only thing that can go wrong is the K. So with the K we can calculate. So I use this in such cases I definitely take three methods. The ACRS online calculator, you put the K as this and then to get the result. I use that Bibinex Impress also. It is what I found is it is as good as eye hands.
Yes. Yeah. And their injectors are super actually.
Yeah, superb.
Yeah. Even the eye hands and their injectors, you have to really, stretch the cornea and put inside. But this like goes smoothly. Yeah.
So anyone has experience with that Rainer EMB lens?
No, not right.
Kiran? No.
So, no, eye hands, and you said you don't counsel them. How do you differentiate between technics and eye hands? Like the package will be different, no?
Look, of course, I think a lot of depends on most of the patients I operate are patients whom I have been following up for glaucoma for many years. And generally, and I've also noticed this, like the practice is such that practically nobody will want to do a trifocal and spend that much money. But nobody, I mean, in the list I'll find hardly any patient who will be using an Indian, that kind of lens. So everybody is very happy to spend 40,000-45,000. So that kind of difference between techniques and eye hands practically never matters.
Okay.
So we kind of tell you this is the lens that I kind of prefer. I actually kind of write eye hands / Clarion. That is usually taken. That's just the nature of practice, I think.
Okay.
So that difference of say 3,000 or 5,000 does not seem to matter for the kind of patients we generally see. But we also don't have those patients who will put in a panoptics, multiple times. That also doesn't happen. And that applies to our mixed procedures also. We can't convince patients to put in a 1.5 lakh stent. But if you charge only 35,000 for a KDB, there are enough number of patients. Every OT you can do 2-3 cases. So that extra 35,000 people are okay to spend. But for 1 lakh, 1 plus, that is too much. That is too much.
The 1 lakh, I think, is the barrier, mental.
And but then you have practitioners, for example, in Netradama and all, Dr. Sri Ganesh and all, who will put any number of eye stents, not a problem, because that is the level of practice they have. So if somebody has basic glaucoma and cataract, it's like femto plus eye stent. That is only when this surgeon will do. Otherwise, it will be left to some other, Junior surgeon. One patient actually told me this, so that's how I know.